Hello everyone, I am Dr. Singaram. In this session, I will be doing the discussion of recall questions in pediatrics which were asked in this NEET-PG 2023 exam. So, let us get started with the questions. The first one is about a child has a fever and a rash spreading from the face and behind the ears to the other body parts. On examination, Koplik spot is present, the likely diagnosis. It is a very standard and often repeatedly asked exam question. This is a child with a fever and rash, and presence of Koplik spot would point to the diagnosis as typical measles infection. We all know that there are many conditions which will be presenting with fever and rash, but presence of Koplik spots is always pathognomonic of measles infection. Remember, rubella can also have fever, rash which starts from behind the ears and the face and spread to the rest of the body, but the total duration of the rash in rubella will be only for 3 days, and that is why it is called as a 3-day measles. And in rubella, Koplik spots are absent, so that is why that condition is already out. Chickenpox is not characterized by a rash which will be starting from behind the ear. Instead, in chickenpox, what you get usually is a vesicular type of rash, what we call it as a dewdrops in a rose petal appearance, and usually starts in the trunk area, okay, and then spreads to the extremities. And in chickenpox or varicella also, Koplik spots is absent. Mumps is not even characterized by presence of rash, so that condition is automatically out. So the answer is going to be measles. This is a typical description of the Koplik spots. What you can see is something like a white or grey grains of sand appearance which is seen in the buccal mucosa opposite to the second molar teeth. This is the classical description of the Koplik spots which is pathognomonic of measles infection. Usually remember, Koplik spots appear in day 2 to 3 of the illness. It is usually in the prodromal stage only the Koplik spots appear. You all know that the prodromal stage is characterized by fever and other signs like cough, coryza, conjunctivitis, and in the day 2 to 3 you get the Koplik spots. And please remember, in case of measles infection, day 4 only the rash will appear, and the typical rash is the maculopapular rash which starts from the face and behind the ears and then spreads downwards. Okay, this is a typical description of rash and Koplik spots in case of measles infection. Moving on to the second question. A 3-month-old baby came with the complaints of deafness, defects in the vision and patent ductus arteriosus. Which of the following is a diagnosis? This is actually a triad characterized by deafness, visual problems and heart defects, which is seen in one of the torch infection. What is that torch infection? It is again a repeatedly asked and a common question which I am sure most of you would have got it correct. What is that? It is congenital rubella infection. That is what you need to remember. Answer is rubella. The triad is deafness, which is sensorineural hearing loss, visual defect in the form of cataract, and heart defect, it is in the form of patent ductus arteriosus. This is supposed to be the triad in case of congenital rubella syndrome. Please remember, even though in the triad the characteristic visual abnormality is cataract, the most common ocular finding in case of congenital rubella syndrome, which has been asked previously in one of the exams, the answer is going to be salt and pepper retinopathy. Salt and pepper retinopathy. And please remember, among the torch group, only rubella is characterized by heart defects in the form of patent ductus arteriosus. In all the other torch infection, heart defects are usually not a feature. These are some of the special points about congenital rubella syndrome which you should be knowing. We had one more question about torch infection also, and the question goes like this: infant with hepatosplenomegaly, thrombocytopenia and periventricular calcification, what is the diagnosis? Okay, this is again characteristic of one more torch infection, and the clue here is the presence of periventricular calcification, because hepatosplenomegaly, thrombocytopenia can be seen in many torch infection, but presence of periventricular calcification points to the diagnosis of cytomegalovirus infection, which is the most common torch infection as well. This is a special point about cytomegalovirus infection. The other features of or other characteristic findings in cytomegalovirus infection include sensory neural hearing loss as well as chorioretinitis. Along with that, brain is also damaged, resulting in microcephaly. And please remember, the treatment for congenital CMV infection would be in the form of antiviral medication, which is ganciclovir. These are the salient points about congenital CMV infection. Now, among the other given option like rubella, HSV and toxoplasmosis, one condition is also associated with intracranial calcification. What is that? Yes, it is toxoplasmosis, but the point about toxoplasmosis is that it is not periventricular calcification, it is diffuse parenchymal calcifications. Diffuse parenchymal calcifications. Okay, so that option can be ruled out. Rubella and HSV is not associated with calcification, intracranial calcification, so they are also effectively ruled out. So, the answer for this question is congenital CMV infection. The next question is related to anthropometric measurements in a small child. What is normal in an infant with 2.8 kg birth weight? This is something like a statement based question where you have to analyze individual statement and come to the answer. Weight gain of 300 grams till 3 months. Is it a true statement? It is an absolutely wrong statement, because in 1 month itself the baby would increase 30 grams per day, meaning in 1 month itself it is around 900 grams per month. Okay. So, 300 gram till the age of 3 months is absolutely a wrong statement. That will be the pattern of increase, which will be like 900 gram every month till the age of 3 months. It will be till 3 months. After 3 months, it will be like increase in 400 gram per month till the age of 1 year. This will be the usual pattern of weight increase. So, the first statement is absolutely a wrong statement. Increase in the length of 25 centimeter in a year, this is a correct statement, because the length at the time of birth is approximately 50 centimeters. We all know about it. In the first year it increases 25 centimeter. So, the end of 1 year the height is around, or the length is around 75 centimeters. Then in the second year there is an increase of 12.5 centimeter. So, the end of 2 years it is approximately 87.5 centimeters, and after 2 years there is approximately an increase of 6 centimeter every year. This is the pattern of height increase. So, that is a true statement in the answer for this question. Look at the option C, anterior fontanel closure by 6 months of age. It is not 6 months, it is 9 to 18 months is the time when the anterior fontanel would close. So, that is a wrong statement given. Weight under 75th percentile and height under 25th percentile. Is it normal? It is absolutely normal. Remember, weight or height we will always determine in terms of percentile according to WHO chart, and according to WHO chart a range between 3rd to 97th percentile is considered to be a normal value. So, it is not anywhere near to what is given in the option, hence that is also a wrong statement. So, the answer for this question is option B, which is increase in the length of 25 centimeter in 1 year. Okay. Then we move on to the next question. A newborn presented with a chest retraction, dyspnea and lethargy. The baby is diagnosed as having respiratory distress syndrome by a pediatrician. This occurs due to deficiency of. So, this is a simple question where they are asking you a respiratory distress syndrome or RDS is due to deficiency of. We all know that RDS is due to deficiency of the surfactant, to be very precise, mature form of surfactant. Okay. So, among the given options like lecithin, sphingomyelin, diphosphatidylethanolamine, ethanolamine, dipalmitoyl inositol, which is the most mature form of surfactant, which if it is deficient is going to result in respiratory distress syndrome, the answer is lecithin. Okay. Lecithin is also called as the phosphatidylcholine, which is the most mature form of surfactant, and the deficiency of that would result in respiratory distress syndrome. Now, please remember, this is the composition of the surfactant. Surfactant is nothing but a mixture of phospholipids and proteins like SPA, SPB, SPC and D, like that. These are all surfactant protein, that is what is represented SP. All the other things are phospholipids, and you can see majority of the phospholipid is the phosphatidylcholine, which is nothing but lecithin. This is how a mature surfactant would look like, characterized by predominance of phosphatidylcholine or the lecithin. Okay. Now, in the past we used to determine a ratio called lecithin-sphingomyelin ratio. Lecithin is a mature form and sphingomyelin is a immature form. More the ratio, more lecithin, which means it is a mature surfactant. Less the ratio or more sphingomyelin, it is a immature surfactant. We also used to do something called measurement of lamellar bodies in the amniotic fluid for assessing the lung maturity. But please remember, nowadays these tests are becoming almost obsolete because we are not depending on these tests to assess fetal lung maturity. One of the most important indicators of fetal lung maturity is the gestational age itself. This is an important point. Okay. And gestational age beyond 34 to 35 weeks would tell you that the surfactant is already mature and the chance of RDS is very, very less. Okay. So, please remember, all the tests for fetal lung maturity which we were previously using are all now becoming obsolete, because the most important predictor of lung maturity is the gestational age of the baby itself. Okay, right. So, that is about few points related to this question. Moving on to the next one, a 10-year-old child with a weight of 30 kg has pH of 7.01, which is an acidic range. Sodium is 158, which is higher side. RBS, the random blood sugar, is 550, definitely on the higher side. Urine sugar 3 plus, that is sugars are excreted in the urine or glycosuria. There has been a history of loose stool for 2 days. On examination, there is a severe dehydration. This is an important clue. As per the ISPAD guidelines, what is the initial treatment? ISPAD means International Society for Pediatric and Adolescent Diabetes. Okay, they have given the guidelines for management of. See, what is the diagnosis in this particular child? It is DKA. What is that? Diabetic ketoacidosis. Okay, an acute presentation in a child with the diabetes. Okay, and that too with dehydration and all, you have to think about DKA. Okay, diabetic ketoacidosis. So, among the given option, which will be the answer? Obviously, it will be ABC, resuscitation along with fluids, and please remember, it should be insulin after that, but it is after 1 hour according to the guidelines. So, you have two options like that, option B and option D, both saying ABC resuscitation with fluids and insulin later after 1 hour. Okay. So, which one will be the differentiating point? It is the amount of fluid, whether it is 10 ml per kg of fluid or 20 ml per kg of fluid. Answer according to the guidelines, it is option D, which is 20 ml per kg of fluids. Generally, normal saline is what we give. Okay. So, perform ABC and perform or assess ABC and stabilize airway, breathing and circulation, and then you give fluid which is 20 ml per kg of normal saline, and then later after 1 hour you go for the insulin infusion. Okay, right. This is a snapshot of the ISPAD 2022 guidelines for management of diabetic ketoacidosis. As you can see, at the time of admission, you have to classify the children. After confirming diabetic ketoacidosis, you have to classify the children into 3 categories. One with a severe dehydration with shock. Okay. Second is moderate dehydration, and third is minimal dehydration. Okay, right. In our particular question, it is clearly mentioned severe dehydration or shock. So, we have to follow this particular limb. Okay. Obviously, it should be airway, breathing and circulation, that is ABC. After that, see what is written, you have to give fluids. What is that? 0.9% saline, that is normal saline 20 ml per kg, bolus has to be given, and after 1 hour, can you see that? After 1 hour, okay, starting 1 hour after the IV fluids only, you have to give continuous IV insulin infusion. So, this is what is the guideline saying and the answer for this question also. Okay. Because it is severe dehydration, you have to give a fluid bolus which is 20 ml per kg of normal saline, and after that, once the fluid status gets stabilized, you have to go for IV infusion starting after 1 hour. Okay, right. So, just a quick review of what is the definition of diabetic ketoacidosis. You have hyperglycemia, which is characterized by blood sugar more than 200 milligram per deciliter. Then for evidence of acidosis, you should have a venous pH which is less than 7.3 or a serum bicarbonate less than 18 millimoles per liter. That will be the evidence of acidosis. Then ketosis would be in the form of ketonemia, that is presence of ketone bodies like beta hydroxybutyrate in the blood, which is not always available. So, in our settings, usually the test done is estimation of ketone bodies in the urine, okay, or ketonuria. Okay, right. So, these are the important criteria for diagnosis of diabetic ketoacidosis. Moving on to the next question. A child is brought to the hospital with features of respiratory distress and biphasic stridor. Prior history of URI is present. The radiograph is shown below. What is the diagnosis? So, this is a respiratory problem where the child is having breathlessness, stridor along with the preceding URI history. Okay. Stridor would tell you there is a problem in the laryngeal area, and the X-ray is going to provide to you the diagnosis. What is the X-ray depicting? The classical narrowing of the airway, which is pointed by the arrow also like this narrowing, and can you see the maximum narrowing is at the level of the glottis area, okay, or just below the glottis, or what we call subglottic area, there is a maximum narrowing. Okay, right. So, which is this condition? Before that, what is the name of this sign? The name of this sign is called steeple sign. Steeple sign, which is very classical of Croup. Other name of this condition is acute laryngotracheobronchitis. Because of the inflammation only, there is a narrowing of the airway presenting like that of a steeple of a church. So, that is why it is called as a steeple sign, which is very characteristic of acute laryngotracheobronchitis. Okay, the complete name should have been laryngotracheobronchitis. Okay. So, this is again a repeatedly asked question. The X-ray picture also has been asked repeatedly so many times. So, this should be a straightforward one. Answer is acute laryngotracheobronchitis. So, just a few points about Croup. The causative organism is a viral infection usually caused by para-influenza virus, especially the type 1. Okay. This is the usual virus causing this infection. Second thing, it is characterized by a croupy cough, loud cough, also called as a brassy cough. Okay. Stridor, okay, is the next characteristic finding, and stridor is usually inspiratory but can be biphasic as given in the question also. Okay. These are the characteristic clinical aspects of acute laryngotracheobronchitis. As far as the management goes, it is a viral infection. So, do not need to give any antibiotics, but the cornerstone of management would be number 1, oxygen inhalation, especially humidified oxygen inhalation. Number 2, if they ask you the drug of choice for management of this condition, it is steroid, and the usual steroid is dexamethasone, and usually given as a single dose of 0.3 to 0.6 milligram per kilogram, which will be the drug of choice in the management of Croup. So, that is about this particular question. Moving on to the next question. A 3-month-old baby had jaundice and clay colored stools. The baby has conjugated hyperbilirubinemia. Remember, clay colored stools is one of the characteristic clinical features of a child who is having jaundice with increased conjugated bilirubin levels. Okay. Now, liver biopsy shows additional finding, based on which only your answer is going to be. It shows periductal proliferation and fibrosis. What is the diagnosis? Remember, it is a small baby presenting with conjugated bilirubin increase. So, you look at the options, okay, Crigler-Najjar syndrome, Dubin-Johnson syndrome, Rotor syndrome and biliary atresia. Remember, in this particular condition, Crigler-Najjar syndrome is already out because it is characterized by increased unconjugated bilirubin. You all know that Crigler-Najjar syndrome is a condition of UDP-GT defect or decreased conjugation problem, thereby resulting in increased unconjugated bilirubin. Whereas Dubin-Johnson, Rotor, biliary atresia all are characterized by increased conjugated bilirubin increase. Okay. Remember, Dubin-Johnson syndrome and Rotor syndrome usually do not have a neonatal presentation. They are somewhere in older children or adolescents is where they usually present. So, both these options are unlikely. Not only that, the biopsy finding of periductal proliferation and fibrosis is very characteristic of biliary atresia and will be the answer for this particular condition. Remember, whenever a small baby presents with increased conjugated bilirubin level, we call that condition as neonatal cholestasis, and there are two important conditions in neonatal cholestasis, which includes neonatal hepatitis, also called idiopathic neonatal hepatitis, and one more is EHBA or extrahepatic biliary atresia. What I have put up is differences between the two conditions based on liver biopsy finding. Remember, liver biopsy is the most important on the diagnostic investigation in these two conditions. So, you should know the differences between the two in liver biopsy findings. Number 1, hepatic architecture. You can see that it will be very abnormal in case of neonatal hepatitis. That is what I have written as disarray of the hepatic lobules and all. Whereas in extrahepatic biliary atresia, usually the liver architecture or the hepatic architecture is normal. Giant cells, please remember, are very characteristically described with neonatal hepatitis, but the point to be noted is they can also be seen in biliary atresia. So, it is not actually a differentiating point between the two conditions. Okay. Then portal reaction, okay, that is a portal triad area. You get intense inflammation in case of neonatal hepatitis with only a minimal fibrosis, whereas extrahepatic biliary atresia, it is marked fibrosis, only small inflammatory cell or very less number of inflammatory cell like lymphocytes will be present. That is what you need to remember. Fibrosis is a characteristic feature. Next is about neoductular and periductular, that means surrounding the bile ductules. Proliferation is a characteristic feature of biliary atresia only, and it is very rare in case of neonatal hepatitis. Now, going back to the question, it is very clearly mentioned that the liver biopsy shows periductular proliferation and marked fibrosis, which is very classical of biliary atresia, and hence the answer for this particular question. Moving on to the next question. A 3-week-old child presented with the paroxysms of cough followed by apnea. The total leukocyte count is elevated. What is the treatment? You have the options like azithromycin, amoxicillin, cefixime and ciprofloxacin, all an antibiotic, meaning they want you to think in terms of a bacterial infection in a small child. And the characteristic clue in the question is paroxysms of cough. What is that infection which is characterized by paroxysms of cough? Yes, it is nothing but pertussis. Okay, right. Now, this is a common condition and a common clinical feature also we know about. Only thing which may cause a slight confusion is the apnea, which is generally a finding which we do not associate with pertussis, correct. But here is a learning point that whenever pertussis occurs in a small child, okay, the features would be slightly different, which is what I will be enumerating in the next slide. Let us finish off this particular question. The pertussis, if it is going to be the diagnosis, the treatment of choice is going to be, yes, macrolide antibiotic, and among the given options it is azithromycin. Okay, right. Now, this is what I was talking about as the clinical aspects of the pertussis or the whooping cough. We know that in a classical pertussis, it will follow something called 3 stages. The first stage is the catarrhal stage or the first 2 weeks of illness, wherein you will have this fever, lacrimation, rhinorrhea, as well as the conjunctival suffusion or redness. That is what will be the catarrhal stage or the first 2 weeks of illness. Then after that, that is from after the 2nd week onwards till the 6 weeks, it is called as a paroxysmal stage, where you have the typical whooping cough, okay, followed by post-tussive vomiting, that means vomiting after coughing. These are characteristics of paroxysmal stage, and after that only is a recovery stage or the convalescent stage. This is how a classical pertussis will progress. That is what we know about, and this is something which occurs in a older child. But whenever pertussis occurs in a young child, that is less than 3 months of age, okay, it follows a entirely different course. For example, the first stage, the catarrhal stage, is usually not noticeable or it is insignificant. Child may have just only a mild fever or even not even fever also. So, that is what I have written, catarrhal stage is insignificant. Okay. Then in the paroxysmal stage, that is the 2nd stage, whooping, which is supposed to be very characteristic of pertussis, is actually infrequent. That is the point I want you to remember. They will have paroxysms of cough, but whooping as such, whooping cough as such is very insignificant or infrequent in a child less than 3 months of age. And this is the very important point from Nelson textbook of pediatrics. It's very clearly mentioned that apnea and cyanosis can follow a paroxysm of cough in a small child, or apnea can occur as the only symptom also even without cough also. So, the learning point here is whenever pertussis occurs in a young child less than 3 months of age, apnea is one of the important symptoms, even more important compared to a cough also. That is the point which I want you to remember, and hence the clinical correlation with this particular question. Moving on to the last question in the pediatrics part, it is chloride levels in sweat are calculated in the diagnosis of which disease. Okay, this is again a very straightforward and repeatedly asked exam topic, which is about cystic fibrosis. Every competitive exam there is one question about cystic fibrosis. This time it was a very simple question like estimation of sweat chloride levels in which condition it is cystic fibrosis. Remember, for diagnosis of cystic fibrosis based on investigations, there are some important things to be done, one of which is sweat chloride. And please remember the diagnostic criteria of cystic fibrosis. It should be 2 elevated sweat chloride level, not a single value, 2 elevated sweat chloride levels of more than 60 milliequivalents per liter. This is something which is important, and it should be applied on 2 separate days. That is something which is very characteristic or diagnostic of cystic fibrosis. Second, identification of cystic fibrosis mutations, but it should be 2 cystic fibrosis mutation, not a single mutation is enough, 2 mutations are required. Third would be an abnormal nasal potential difference measurement. Okay, even a single value abnormal can be taken as diagnostic of cystic fibrosis. So, we have 3 important things like investigation to make a diagnosis of cystic fibrosis. Any one is sufficient, but remember, if you want to make a diagnosis based on sweat chloride, it should be at least 2 elevated values. Okay. And finally, how is sweat chloride levels estimated? It is by a method called pilocarpine iontophoresis. Okay, iontophoresis means usage of an electrical current to push the pilocarpine into the skin area where the sweat glands will be stimulated. Following that, sweat will be produced, which you can use it for estimation of sweat chloride. That is what is the process of pilocarpine iontophoresis for sweat chloride estimation in the diagnosis of cystic fibrosis. With that, I conclude the session on recall question discussions in pediatrics which were asked in NEET 2023 exam. Thank you.